All right. So I'm aware that we will still have people kind of filing in as the time goes and everything. But we have a fair bit to go through and two amazing people joining us today who will be able to talk about this in much more detail than I will. So I'm hesitant to take up too much time of waiting. So we'll just let people file in as they go. But yeah, thank you everyone for joining us today to celebrate National Palliative Care Week with ACON's online palliative care webinar for our LGBTQ plus community. So I'll just start us off with an acknowledgement of country. I want to acknowledge that all of us are coming from unceded lands today, and I want to acknowledge the traditional owners and custodians of the many lands we are all joining this call from. I'm calling from the beautiful Camaragal lands, and I invite you, if you want to comment in the chat where you are calling in from and what country. This artwork is by Wanarua artist Clarissa Pergolino for the Into the Dreaming PDF booklet, which is really great. And so if you'd like, during this acknowledgement, kind of look at that and maybe think about what that inspires for you and how that artwork makes you feel in the context of this palliative care journey we'll be taking together. So yeah, just want to pay my respects to elders past, present, and emerging, and to extend that respect to any Aboriginal or Torres Strait Islander people who are joining us today, particularly those experiencing sorry business. Always was and always will be Aboriginal land. So to kind of kick it off, I thought I'd give a quick overview of how we're going to be going today. So, my name is Zoe. I use she, her pronouns, and I'm the Community Health Promotion Officer for End of Life and Palliative Care at ACON. And I feel really privileged to be, making this presentation and being able to put this out to the community for National Palliative Care Week. There's loads of events. If some of you joined us earlier, you might have heard us talking about a few. But yeah, make sure if you don't know much about it, to use this week as a great opportunity to see all the fantastic things that are happening around you. So to give a quick overview of how things are going to run today, I'll give you a bit of an introduction about ACON and about our palliative care work, and kind of my role and how that's involved. And then we're lucky enough to be joined by two fantastic speakers from various parts of the palliative care kind of work, Julie and Brendan, who are both going to be sharing a little bit of their insights and kind of describe palliative care in a general sense and then also specific to their work, and really kind of, I guess, dispelling a lot of the myths that might be around palliative care. So after that, we're going to have a bit of a Q&A. So we have some questions that some of you submitted when you registered. So thank you very much if you did so. But please feel free to ask more questions in the chat as we go. We will try and get through lots of them. I think lots of those questions will be kind of answered incidentally as we go and through the presentations. But we may not get to all of them. So if there's a burning question that we didn't get to, please feel free to email me, and we can consult the team and try and help you a bit more with that. I know we have some wonderful clinicians joining us today as well. And yeah, we may not get through to more of the clinical questions today. But again, I would love to chat to you more if you want to discuss training or things like that. So feel free to get through to me there. Last housekeeping matter, we are going to be recording this webinar, and because we're in the webinar format, you won't be able to kind of turn your video or audio on, but just be mindful of the comments that you're putting in. If they're public or not, they may be seen. Yep, we're going to be sending out evaluation forms once we're done with this. Would love your feedback so I can keep on making events like this more interesting to you. And yeah, we'll also be sending through some of the resources that we talk about today. So without further ado, ACON and the Love Project, in case people don't know much about it, ACON, we are a proud LGBTQ plus community health organisation. We've been operating in New South Wales for 40 years now, and we're all about empowering LGBTQ plus people and people living with HIV to live their healthiest lives. The Love Project specifically is a fantastic resource for our older community members. It's really spearheaded by Russ. Um, and there's a huge amount of social workshops really aimed at reducing isolation for our community. And yeah, this, I guess, recent push to do more palliative care work is part of our funding that we've been really generously granted from New South Wales Health to keep on expanding our Taking Control toolkit. So that's our online resource that is kind of everything we might need to know as LGBTQ plus people about palliative care and kind of planning and being prepared and increasing our death literacy. So it's been developed over the years to include loads of things, definitions, legal tips, ways of dealing with grief and just increasing death literacy. And yeah, these projects that we're rolling out are part of putting some programs to that as well, which is super exciting. Part of that, looks like our legal workshops that we did, our advanced care planning workshops. You may have heard of us talking before about our death conversations coming up. So if there's anything that you particularly want to see, please also get in touch with me because we're all about trying to increase death literacy for our community. So I guess why we want to do this is because death literacy is a really key skill that I think Australian general public can really benefit from, learning more about. We can never be too prepared for this kind of stuff. But I know specifically as the queer community, we also all know that our healthcare doesn't always look like, the way society may assume our healthcare looks like, and it may not fit the norms to everyone. And there may be things that are really important to us that may not be assumed by the people that we may interact with. So when we're doing these, it's really important that we kind of think of this stuff early to be prepared for the future, making sure that our loved ones are protected and taken care of, and making sure that our wishes are respected as well in our life and after our lives as well. Um, so I think that's kind of the preamble that I wanted to do about ACON. We will be sending out more information about this, of course, as well. But I think now we'll kind of get into the presentations. And so I just want to take a second to everyone can take a breath and to come into this space. So we are talking about something that um, can feel really empowering to discuss because it's not talked about all the time in community, and that can make us feel excited and want to chat about this stuff more. But I think it's also really good to acknowledge that this can be really tough to talk about. It can be really distressing. And also, as the queer community, we can have some real kind of stories and distressing kind of attachments with this. We know that we've, yeah, got experiences that really inform this topic potentially being a little harder to hear. So please feel free to log off if you need to. These sessions will be recorded and you can always watch again at a later point. We will also be staying back a little after this has finished in case you're really concerned about something and want to let us know. But just remember that, taking this journey, you're held, and we're really glad that you're joining us here today. So, acknowledging that we will be dealing with themes of death, dying, and mourning. But we are really glad that you've taken this step to learn about that with us today. So without further ado, I would like to introduce Julie, who's going to discuss the Greater Choice and Palliative Care Program and general palliative care.
Excellent. Thank you, Zoe. I would like to start by acknowledging that I currently live, work and learn on Wiradjuri country. Wiradjuri country borders a number of other Indigenous land, and I too pay my respects to elders, past, present, and emerging, and recognise this always was and always will be Aboriginal land. So this is a very generalised look at what palliative care really is to vast range of people in our community. Most people tend to think of it as just for end of life, when actually palliative care is about maintaining quality of life. So you can see it is holistic. It is recognises, and Brendan will elaborate on that a little further in his presentation, but recognises the holistic nature of caring for someone who has a life-limiting condition, and that it is about their beliefs, their goals, their values, spirituality, their environment, managing the symptoms so that they can maintain the highest quality of life they can while living. So it is, you know, a very generalised thing. Once we can break down those barriers that says only palliative care is only for end of life, I think the community will really benefit from exploring palliative care for themselves, and particularly if they are living with a carer or they have a carer, that staying at home, if that's your wish, for as long as possible, can be done with involvement through palliative care. So it's the next slide there, Zoe, is on when palliative care is needed. So I've touched on that just a moment ago, that generally palliative care can start from diagnosis. So say, for example, someone has been diagnosed with dementia. That would be a good time to then start to understand what systems and supports can be put in place so that that person can maintain the highest quality of life while they're living with their diagnosis. So palliative care will come in and out of their lives. So come in, do an assessment, find where those needs are, and then drop back out because the patient is stable. If the patient becomes unstable, and by that I mean pain may have increased, they may need to consider looking at different medications, those sorts of things that their medical team will work on. But that's when palliative care may come back in and say, right, what we need here is some equipment. This will help with staying at home comfortably, navigating the various challenges that come up with that. And of course, you know, it doesn't stop at death. It certainly continues around that bereavement support and ensuring that there is access for the loved ones left behind to access appropriate grief and bereavement support. And that will be according to whatever their needs are as well. I feel really passionate about sort of saying, actually, grief does not have to go in a linear fashion, and it does not have to finish after 12 months. You know, you can take as long as you need to grieve, and grieve in whatever format or you know, expression works for you. It won't be too much longer, I'm sure, Zoe, that you and I will be able to, you know, share our grief and bereavement resource for the LGBTQ plus community, recognising that it may be complex, and that may be due to things like historical trauma. It may be around things like being misgendered in death, may be around not recognising the patient's family as opposed to the patient's family of origin. So yeah, it's a little bit more complex. Um, I mean, that sounds negative. It just, requires different um, resources and a different approach. So we hope we'll be able to cover that. So palliative care is for everyone. I think it's really important to recognise that whatever that life-limiting condition is, it doesn't have to be cancer, which seems to be the one that most people think about. It may be renal issues, it may be dementia, and I think there's a slide coming up on that. It may be, of course, any of those life-limiting or chronic conditions. So we can see there's a range there. We say that it's for everyone because it doesn't limit, if there's no limitations based on the diagnosis, but also that it can be for young people, uh, people in the prime of their lives, as well as older people. So it's not limited to a separate age group, but broadly for anyone of any age um, and any, I mean, any lifestyle, belief system, those sorts of things. So, what are the barriers? Um, it's important to recognise that while we talk about um, barriers as uh, limiting access to palliative care, we also recognise that for people, certainly within the LGBTQ plus communities, that those barriers may be very real, but may be undetectable to clinicians or the health system that doesn't recognise the unique qualities or the unique needs of the rainbow community. So if there are barriers, that doesn't mean that the patient or the carer has the problem. This is a systemic issue and one that continues to need to be addressed in a range of ways, not just through training, but through attitudinal, societal, and systemic change. So recognising that is really important. Let's see, what are we doing next? This is my program. So I currently am employed as the Greater Choices for At-Home Palliative Care project worker. It is just looks like alphabet soup when I put it together. I can't make a proper acronym out of it. So it's a very long name. Essentially, working for the Primary Health Network. This project is federally funded and therefore is across all PHNs across Australia. The project aims to improve access to at-home palliative care for all the community. We build awareness around dementia as a life-limiting condition. We provide support and education for community and for carers. Let me clarify that. We don't provide any services, but we commission services. We support agencies that are already doing it. We build capacity in primary care to support the quality palliative care, to support quality palliative care at the right time, in the right place. We want to improve palliative care outcomes in general practice through quality improvement, and we want to improve the palliative care approach for First Nations people and other priority populations, and improve equity in access to carer bereavement support in the community. So we have a range of strategies in doing that, and so partly that is around getting out into the community, identifying where the gaps are. And I think that's where my alignment with, certainly with ACON, has been a really positive element to the work that I do, in recognising that it's too easy to forget the diverse needs of our communities, and that resources, conversations, education, light needs to be shone so that we can start to, change those systems that create the barriers. So it's very enjoyable, and certainly getting out and talking to the community is part of that process. Our focus areas are around. Are we going to do the video? You're on mute, but
Sorry, I think I moved you on slightly quickly
that's
there,
all right.
Julie.
I'll do one brief thing, just talking
Please.
about our focus areas, and just drill down a little bit.
Oh,
GPs, close the book on the patient once that patient has died. So it's the carers then kind of have to take the responsibility to say, I'm not progressing well, I'm not doing well, and discussing that further and trying to advocate for themselves. Very difficult when you're in a highly stressful situation. We do a lot on advanced care planning, and ACON have, done a brilliant a couple of webinars on advanced care planning, which are really valuable. So I would encourage everyone to take a look at those recordings. Timely and appropriate referrals, what we tend to see, and again, we don't deliver services, so we only see what the research tells us. And that is that, most people who are have advanced disease are only getting their referrals to palliative care tends to be like the last 3 months of life. And it's almost too late then to improve the quality of both the patient and the carer's life at that point. So timely referrals are really important as early as possible. And access to palliative care for diverse communities. So undertaking community consultations and relevant partnerships to support cultural safety for all groups. Okay, so this is the video. Murrumbidgee Primary Health Network has commissioned this video as part of their broader work in raising the awareness around what palliative care is. It does discuss death, dying, and grieving. So we want to pay our respects to the people that are within the film. Paul, one of the characters you'll see, remains with us and is well known in the community. And we do thank the participants for providing permission that this can be shown, and thank Murrumbidgee Local Health District Specialist Palliative Care for its production. So enjoy.
Palliative care to me is the care of the living.
David is my full-time carer, and he does look after me. Particularly since I've been sick, David has really stepped up to provide really, really good care, and he's just always there. I know I can count on him. I quite often tell people how blessed I am to have David in my life. He has always stepped up.
I guess sometimes in your life you, I would say, romanticize things of how you think they will be, but sometimes they can be very, very different and like sort of hit you left field, I guess, like Paul's illness. I'm just so thankful I've still got Paul here today, and we can still share each other. Because I think I'd be very lost without him.
The thing is, we don't know exactly what's ahead of us. It doesn't particularly worry you, but you can accept it. It's still harder on the partner, I feel, than anybody else.
He said, "You want to get married?" He went and got me my ring. We had about 70 guests, all of my favourite people, and I stayed until the very bloody end of that wedding. I was exhausted and I was tired, but I was not going home. My husband put me in the wheelchair and tucked me in with all my blankies and pushed me home, because we got married at the pub that was 2 doors up from our house, nice and simple. And he pushed me home, and that was our wedding.
She made me laugh. She made me remind myself that even though she was at the end of her life, it's important to celebrate those times and be able to share that joy with somebody, even me, a stranger a few months ago.
We see them, we see that they are a person. They aren't just a number, they have a whole life, and they are not just their disease.
I have cancer, but that's just one part of me. It's not the be-all and end-all, it's just one part of me. I used to be a nurse, and I really miss nursing. I'm lucky I've got other pursuits, so I can do little bits and pieces in the garden.
Palliative care to me is the care of the living, because Barry is still alive and I'm alive, and hopefully making our life as good as it can be during this period. I don't think it'd be as good as it is without that palliative care team. I've got someone who is a backup for me, that I'm not alone.
All I knew was what the word palliative meant, that you're dying. I didn't know all the little things that come with palliative, which these amazing people deal with on a daily basis. They are there for me every moment of every day. When my family aren't there, they are the ones that I call. So they have become my second family. They may not know that, but I hope they do now.
They are the one who help me and kids to just stay focused on our health, and for kids to tell them what dad is going through, what mom is going through, and how we can, go out of this situation. It was only Sheridan who explained to them that dad is too sick to survive. Maybe he's not going to be with us one day. And they listened to her so carefully, and that was just a relief.
The most rewarding part of my job is being able to come to work every day and see that I've accomplished something, whether it's something small, something big, with my patients and their families.
You are coming to the end of your life, a very delicate and in some ways vulnerable stage, and you cannot operate as a palliative care professional without giving all to not only the person but their loved ones and their community.
Palliative care is more than a patient and their diagnosis. It's more than their illness. It's reaching out to another person with compassion, with empathy, and with kindness.
Palliative care is more than, the medical side of things, the treatment side of things. It's about involving our palliative care volunteers. It's about involving our carers and having a holistic approach that can support everyone involved in a patient's palliative care journey.
Palliative care is more than any other nursing job I have ever done in my life. It's the culmination of the whole. It is more than fitting a system. It is about the person, their family, and just getting everybody in together just to move through that time.
What do we think?
Oof, it's a beautiful one. The PHN should be very proud.
Yeah, that's lovely.
Yeah, yeah, they really are. It is a challenge, but it's, you know, the gift of uh, being vulnerable to caring for someone as they get near the end of their life is extraordinary. So there is information in these slides on building death literacy, but in order to keep things kind of moving along, I'm happy to rush through death literacy. It is really important, but we get to death literacy by good health literacy, and recognizing that, you know, it's hard, but it's so important to just have start with having those conversations when you're well. So that's our take-home message. And the theme for National Palliative Care Week: what's your plan? So make a plan. Write it on a napkin if you need to. Write it on a fan. Like, you know, have a plan. Keep it safe. Let your loved ones know what's important to you.
Awesome. Thank you so much, Julie. And I'm sure we'll be still picking your brain at the Q&A, but that was fantastic. Thank you for letting us know all about the work you're doing. And yeah, I guess we'll move on to Brendan, who is going to be able to share his insight as an end-of-life coordinator.
Hi, everyone. Lovely to speak with you all this evening. And I'd like to start by acknowledging that I'm working on the land of the Gadigal and Bidjigal people of the Eora Nation, and pay my respects to elders past and present and any Aboriginal people online with us tonight. So my background, I'm an end-of-life care coordinator. My background is as a social worker, and so I will touch a little bit on the social work role as well as we go along, because that's my passion. But I wanted to start by talking a little bit about some of the things Julie has touched on, so I won't spend too much time on them, but what does palliative care offer, or what might it look like if you're meeting someone from a palliative care service? It should always be based on a person's individual needs. So what is important to them and what do they want out of their interaction with the palliative care clinician? But some of the things that might be focused on are about relief of pain and other symptoms, equipment to support care at home and maintain a person's function and ability to stay at home if that's something that they want. We definitely look at families, and so we don't look at a person in isolation. We look at them in the context of their family, and that is their chosen family, or whoever they identify as their family, and the context of their community as well. Lots of planning about future treatment decisions, goals of care, advanced care planning. What kind of treatment and care does that person want as their illness progresses? Linkage to support services, support around cultural needs, emotional, social, spiritual concerns, and also counselling and grief support. And I'll touch on those a little bit more as we go along. Next slide, if you're ready, Zoe. Wonderful. And this is just kind of a bit of a description about that when you meet a palliative care clinician, they might ask you quite a lot of questions. Hopefully it feels more like a conversation than a grilling, but they'll ask you things about your physical health and symptoms, your emotional and psychological well-being, and talk about supports that you might be able to access if you'd like. We also talk about spirituality and what's important to someone. And I know that sometimes when people hear the word spirituality, they think automatically of religion in some cases. But the way we would think about that is much broader in terms of what's meaningful for a person, where do they get their sense of connection, what makes life important for them, and where do they get richness from in their life. And so it's discussions around that and how we can support that. And then looking at the social, that person in their situation, in their family, in their community, and how we can help them continue to thrive in that. Next slide, please. You can receive palliative care in lots of different places, and Julie touched a bit on this. And so a lot of people may be having palliative care and they may not meet a specialist palliative care service. They might get a lot of their care through their generalist care, healthcare services, so that might be their GP and primary care team. If people have more complex needs, so that might be things like physical symptom needs, it might be about their social and psychological needs as well. functional needs, mobility, they might meet a palliative care specialist service. And so that could be in a clinic, and they might just come in and meet a doctor or a specialist nurse in the clinic, and that's the extent of their involvement for a while. If you're in hospital, you might be under the care of a different team, like the renal team or the oncology team, but a palliative care team might come and visit you and add bits of advice to your care. You can have palliative care at home, definitely with palliative care community teams supporting you at home, or in a residential aged care facility or group home. And there is also speculative palliative care units as well. And as Julie mentioned, your involvement with palliative care might ebb and flow over time based on what you need. So it might be that you have levels of more intense involvement, then periods, if things are pretty stable, you may not need them too much in your life. You're off busy living your life without that interruption. So who might you see if you come to a specialist palliative care team? Now, a big disclaimer, across the state, there are lots of different models of care for a palliative care service. There are different levels of staffing. So just to acknowledge, you may not meet all of these people in a palliative care service. Some services are a bit smaller. There might be a doctor and a nurse service. But in other services, you might meet a social worker, a psychologist, an occupational therapist who their big goal is helping a person meet their activities in life that they would like to achieve, or what's meaningful and important for them, and thinking about strategies, whether that's equipment or advice, energy conservation techniques, fatigue management to help them do the things they want to do. Physiotherapist to help build and maintain mobility, a diversional therapist, dietitian, bereavement counsellor, or Aboriginal liaison officer to support someone's cultural needs as well.
Can I
Now,
add there, Brendan, that there may be speeches
yes,
to help with swallowing, those sorts of issues.
excellent,
That
and
was all.
communication as well. And I think I also left out, depending on how well resourced your service is, you might meet an exercise physiologist as well, or an art therapist. Lots of great options.
Yeah.
I'll just tell you a little bit, because I'm a social worker, about the social work role in palliative care. Often when we talk about social work in the palliative care space, there might be different domains that we're working in. So a big part of our work is around emotional and psychological support. So that can include counselling, anticipatory grief work, and I'll touch a little bit more on anticipatory grief in a moment. Definitely carer support, and talking with a person and their carer, if they have a carer, about what supports are available to them, how they're finding things at the moment, what advice might they like. Legacy work is something else that social workers and some other clinicians in palliative care do, which is talking with the person about how do they want to be remembered, and maybe some strategies about creating legacy for themselves and their network. And we're always keen to meet families where there are children, and giving advice about talking with children about serious illness and how a family can support those children. And how we can support the children. And then lots of practical support, thinking about financial issues, accommodation, legal things like wills or a power of attorney, appointing an enduring guardian, advice about funerals or services, or planning for transitioning into a residential aged care as well, if that's something that the person was looking at. And a little bit about grief, and I was so pleased to hear Julie mention grief before, especially that it's not on a timeline. It doesn't have to be done in a particular way. There's not a cutoff point. Grief is a really natural response to loss. It's normal. It's a part of every person's life, and it can be all through our lives. We often think about death and bereavement in relation to grief, but there's lots of different kinds of griefs that people in a palliative care setting might experience, but also all of us in our lives. And so that could be about changes in relationships and roles, or body image, functional changes, sexuality and intimacy, anticipatory grief, which is the grief that people experience in the acknowledgement that they know that the person that they love might be coming towards the end of their life. And then there is bereavement, grief following a death. And disenfranchised grief is something that I didn't put on the slide there, but definitely, grief that isn't recognized, particularly by other people, but maybe those situations where the importance of a relationship wasn't recognized either. And so there's lots of support we can provide around that. the way people respond to grief is so individual, but it can include things like emotions or a feeling of numbness, maybe a lack of sensing a connection to your emotions, um, changes in your concentration and cognitive changes, physical signs. Often people might talk with us about, I'm not really feeling the way I thought I would feel, but there's other things that are showing up. So things like tiredness or sleep disturbance, gastro upsets, loss of appetite, things like that, that grief is kind of there and it's showing itself in a different way. Social changes, so you might find that you're withdrawing a bit from other people, or you may be feeling a need for more social contact, an impact on spirituality as well, and sense of connection maybe to faith or spiritual practices that can kind of go either way sometimes. Sometimes those things are a really helpful anchor point and support point and a connection within community. For some people, being in this situation can challenge those sense of connection, or they might not be getting um, the um, the sense of support that they expected they might from this faith or spiritual practices, and that can be a double loss as well. There's lots of different things that can help when someone's grieving, and I think it's really important to note that it is so individual, and it might take a little while to find what helps and what works for you. So it could be about talking with someone for support, someone that you trust and feel comfortable with. It might be about social connection and activity, allowing yourself time alone when you need it, rest, physical activity, trying to eat well if you can, religious or spiritual practices. Information can be really powerful, and that psychoeducation about grief, just understanding more about what grief is and what the experiences might be like, can help people maybe feel not so isolated in that, that it can be an experience that other people are having. Counseling and support groups, and it can be really hard, but asking for support when you need it as well can be really powerful. And I'd like to finish by sharing an example of what palliative care could look like. And so I'd like you to meet Will. And just a disclaimer, so Will is not a real person. In the interest of confidentiality, I haven't shared one particular person's story. But Will's story is kind of drawn from lots of different people that I've met and known in my work life. And so there's elements here about what it might be like and what supports are available. So Will is a 56-year-old gay man, and he lives with his partner Stuart, and he was recently diagnosed with pancreatic cancer. And although he trialed active treatment for a while, it became clear that his illness was progressing, and he was approaching maybe the last months of his life. And he was referred to his local palliative care team, but there were a few reasons why Will was reluctant to meet that team and engage with them. And part of that was about his experiences in the health system before, especially invalidation of his relationship with Stuart, where that wasn't recognised, and that his family of choice weren't always involved and included as well. He did agree to meet the palliative care team, and his initial contact with us was with the specialist nurse, Kelly, and she met Stuart and Will and talked about how palliative care could support him, but also really listened to what his concerns were. And she was able to make sure, with Will's consent, that other members of the healthcare team, so the palliative care team and the other people involved in his care, knew what was important to him. And so those important things were about the recognition of his partner and his relationship, his chosen family being able to be around him and involved in his care, especially his long-standing friends, Katrina and Paul. He also met a social worker, and they discussed his concerns. And one of his particular concerns was that his parents, who he had a bit of a strained relationship with, might try and step in and try and take charge of his care or try and make decisions if he wasn't able to express himself. And so the social worker was able to meet with he and Stuart, and he appointed Stuart as his enduring guardian and power of attorney with the support of a solicitor, to make sure that Stuart's role was really clear and that his role as a decision maker was recognised. Talking with the palliative care team, Will was able to talk about what he wanted, and his main goal was to avoid hospital and stay at home. He really didn't like hospitals. He also wanted to have a living wake, so a celebration of his life with people that he loved, and so where he could dance and connect with them. So he worked with his nursing team and an occupational therapist and a physiotherapist to set up his home well. Kelly and her nursing colleagues taught Stuart about how to care for Will at home, along with the help of Katrina and Paul and some other care services that the social worker helped to organise. And he had his living wake at home with all of his favourite songs and drinks, and lots of friends from over the years came and joined him. And then some weeks later, he was approaching the last days of life, and his family cared for him at home, supported by the palliative care service. Um, and after he died, Stuart received a follow-up call from Kelly, the nurse, and also from the social worker, and he was offered bereavement counselling. But actually, he'd said no to the counselling. He didn't feel like he needed it at that point, and that he felt really well supported by Katrina and Paul and their other friends. So I think when I reflect on a situation like that, I can see that the death of Will is an event of real sadness and loss. But stories like this show us as well the power of family coming together, respecting and supporting relationships that can develop between a palliative care service and the people that they're looking after, and that people feel respected. And one of those things is palliative care, the way I see it, is all about relationships. And so the earlier we get to meet someone is really helpful to build those trusting relationships so that they feel comfortable with us coming into their home, or them coming into our care facility in hospital maybe. Um, and also that there's lots of moments of joy that we can find along the way, even amongst the hard times as well. So thank you all for attention, and yeah, happy to hand back over to you now, Zoe.
Thank you so much, Brendan. That was yeah, a wonderful presentation and also a really wonderful, touching story. Yeah, Julie and Brendan, both of the kind of story elements that you've shared with us today are really moving. And I hope also for you all listening, kind of inspire and kind of let us see why it is so great and so important to get on to, yeah, like Brendan mentioned, this stuff early and to build relationships and to not be afraid to build and nurture those palliative care relationships, because it is, comfort care at the end of the day. So, look, we've got bit over 10 minutes for questions and answers. So I know that we've got some being sent in the chat, which is great. We also have a couple that I'd love to get through that were sent in to us early, because I think there's some really great ones there. So maybe what we'll do is we'll just go through as a nice collegiate team and reading some out, and maybe I'll throw some out to all of you. But one question that we had was how can palliative care be accessed by lone senior people, so people who maybe don't have a partner, don't have children, and what might that look like, and what kind of costs could be involved with that? I'm not sure which of you maybe is kind of best to answer that, but Brendan, is that something that you know much about?
Sure. So look, there's a few elements there to talk about, but I think for lone people, people who might live alone, I, again, to repeat, meeting everyone as early as possible is great, so that you can start to work with the care team about what's important to you. And if staying at home for as long as you would like is important, meeting a social worker, occupational therapist is really helpful to start to plan for those things and plan for services and supports. And they might also talk with you about what might happen if there's a point at which the services aren't at the level that can continue to support you at home, and what your options are and where you would like to be cared for. So there's a couple of elements there that a social worker really would be great to meet to help support that planning. There was also a part of the question about the costs of palliative care and fees and things like that. So most palliative care services operate within Medicare. So if you're attending a palliative care clinic, or an admission in hospital, those things are usually covered under Medicare. But as we know in the health system, there's often maybe some expenses that people might incur that aren't necessarily seen first up. So they might be things like prescription medicines, that you might need to pay for. Maybe sometimes the cost of equipment loans or hires, a few things like that that do pop up from time to time. If you have concerns about finances, again, to talk about social workers, asking to meet with a social worker in the palliative care service is a really great idea. There's often things, supports we can access in terms of finances that might help with some bills, or talking about schemes like the Medicare safety net, things like that, that might be able to reduce some costs. And some people then choose to pay maybe for private services that will enhance their palliative care. So it might be private care services at home, or admissions in a private hospital, things like that. Julie, have I not touched on anything there you'd like to add?
Yeah, the only thing that I was thinking about was, and I'm sure a social worker is likely to make a referral to somebody like a financial counsellor, and their role is really to sort of say, how can I work on your behalf and make sure you're accessing all the things that you're entitled to, and managing any debts that may be there. So yeah, and they're free, and they're usually in our area. Anglicare, I think, have a number of financial counsellors, and they can come to you. So it is talking to the social worker and understanding what's in your community, and where those supports are is usually the best bet.
I have one more little thing to add, which people are often not aware of, is a lot of us have superannuation, and there are rules within superannuation and for life insurance that mean if you have a diagnosis of a life-limiting illness, within particular prognosis, you can apply to access your superannuation as a lump sum, and you can also apply to access life insurance before you die. And so that could be something that's really helpful to talk about with your super company, but also maybe with a social worker or a financial planner, because that can be a really big game changer in terms of what you can fund in terms of care at end of life as well.
Awesome. Thank you, both of you, for that. That's really informative for me as well, actually. I was making notes there. I guess this is one that I think, Julie, you and I have kind of touched on in our off-camera chats, but I think you have beautiful ways of phrasing it, and I'm sure you do as well, Brendan. But why is it important to distinguish palliative care from end of life care? And I think the way I interpreted that question that was sent in anyway was touching a bit on the idea of palliative care being comfort care and things like that. So do you want to start off kind of answering that for us, Julie?
Yeah, I think the one truth in this is that we were all going to die. The opportunity to go through a process of knowing that you're going to die, and being supported by the people around you, is not something that anybody would want, and yet the opportunity to complete your business, and to finish things off, is a unique opportunity. So yeah, palliative care, in my thoughts, is around that time frame where there's a known end, in that it's going to be sooner rather than later. I do like the phrase, though, Zoe, that you used in comfort care. And I think that particularly for our First Nations people, is recognising that palliative care has some really negative connotations to it. And I certainly know that Northern Queensland, where they're working in Aboriginal and Torres Strait Islander communities, they're using the comfort care as preferred language, because that's what it's about, is providing comfort, rather than that journeying to sorry business and journeying to dreaming that is often associated with PAL care. Brendan, is that kind of in line with what you would think?
Yeah, I think probably the really helpful distinction that you were talking about there as well is that like palliative care isn't all about dying and that last kind of days or weeks of life. It's a much broader spectrum that can really support someone from point of diagnosis all the way through. And I think sometimes when people hear that word they're worried that, oh, this is where you think I am. You think I'm right here at the
Mm.
end of my life, in the last days of my life.
Yeah.
And look, that is an
You can,
important time, but
yeah, I was just going to add to that that actually you can be receiving active treatment and still getting palliative care. So I think that kind of blows those myths out of the water, that it's not just withdrawing treatment. It is, can be still seeking a curative treatment. If those additional services that you spoke about earlier can be put in place to support that process with a life-limiting condition.
Awesome. Thank you both. I also, I guess, just want to, because I'm looking through our awesome questions that are coming through. So thank you everyone who's putting those in. And I see a few questions talking about voluntary assisted dying, VAD. And so I just want to say this to acknowledge that I'm seeing them all come through, and love that we're talking about them. And unfortunately, I think we are in like the last 4 minutes. So, probably don't have time to touch on what a big kind of topic this will be, but we will send out the link to our palliative care toolkit that I mentioned before, that Taking Control toolkit, and we have a bit of information on that as well. So just want to acknowledge that I've seen that come through, and apologies that we have kind of run out of time for more discussion around this. I guess.
Just wanted to let
Sorry,
Vincent
Russ, yeah.
let you know that we got a lot of lovely responses about the video, Julie. And where can people get it? Where can they find it? And we can possibly put it in our evaluation form and send
For
it out to
sure.
people.
You can really Google it. It is there for everyone to see. They're very happy for it to be viewed and shared.
Right.
Local health district is. It's Paul's still living with us, which is something really positive out of that video. Thank you.
And just to back up what Zoe said about VAD in that conversation, we are looking at doing a standalone in-person or webinar talking more about voluntary assisted dying, because I know the community is really wanting a lot of information about it. So stay tuned.
Look, I appreciate everyone tuning in. I am hesitant. I'm aware that we've got 2 minutes left, but I'm hesitant to ask another question, because I suspect that once I kind of get it out and say how much I appreciate that question, our time will be up. So I think I might close things off here now, and thank you again so much, Julie and Brendan. For such an amazing chat, for sharing your knowledge with us. And both of these amazing people are probably, I think they're putting on a brave face to us, but they are probably besides themselves with how much work they've got going on during National Palliative Care Week. So want to pay real respect to them for coming on and joining us tonight. And thank you all as well for joining us. Like I said, we're going to be sending out our resources that we've mentioned, and also some that I think could be useful just in general, and certainly sending out Julie's video. So yeah, thanks everyone for coming along. Please do our evaluation, and remember to kind of stay engaged, I guess, with this. I think it's so fantastic that you've already done this step of joining the conversation. But feel free to send out the resources that we've talked about today to your community to think about making those plans. Like Julie mentioned, the theme this year is all about making those plans. So getting onto advanced care planning and thinking about all these kind of important things for you, and communicating those, putting them on paper, and telling your loved ones about it. So I guess want to any key thing that I'm missing out here, Julie, Russell, Brendan? We're good to close up.
No, I think a lovely way to finish. Thanks, Zoe.
Absolutely. Thank
Beautiful.
you.
Thank you
Thank you,
so much.
everyone.
Thank you,
And
everyone.
like I mentioned as well, you can all feel free to head off now and enjoy your evenings. But Russ and I will stay on just as everyone's peeling off. And if you are feeling any concerns, feel free to send us a message. But otherwise, reach out to me on my emails afterwards, and I can always support you with any other questions. So thanks so much, everyone.